Yes, ma'am.
Yes, please. And here is your question. Right, if you have read and understood, kindly tell me what is your provisional diagnosis for this patient at this time?
So in view of the abdominal pains and pain and the fall in the level of 125 dihydroxy vitamin D, I would think in terms of polycystic kidney disease.
Okay, can you describe what would be the gross pathology that you'll see? If you can maybe explain what are you looking at?
This is a specimen of the kidney, which is showing multiple cysts on the which showing polycystic appearance,
Okay, can
large.
yes, can you tell me how this condition is inherited, or what is the mode of inheritance of this condition?
PKD gene,
Yes,
the gene 1 and 2.
yes, and it is autosomal dominant condition.
Yes.
All right, can you please tell me the pathogenesis of cyst formation?
They causing an outpouching or a saccular outpouching from the initial tubular structure. This sac is basically filled with fluid that is coming from the glomerular filtrate entering from the afferent tubule system. Slowly, this sac separates eventually from the main tubule and forms into cyst. And the cyst automatically expands as a result of continued secretions from the wall of the cyst and proliferation of the mural epithelium. And also there is also transepithelial secretion of sodium chloride, which leads to increase in the size of the cyst as a whole.
Very
So
good.
as such, the
Okay.
entire.
Can you name few other organs which also has cyst formation in them?
In the abdomen, there'll be a liver, the spleen, the ovaries, and pancreas also can have
Very
cystic.
good. Very good. Okay. Can you name few complications which can result because of this condition?
Because of this, a patient will have prolonged abdominal pain. That there's a possibility of failure secondary to
Good.
infection,
Yes.
uh, present with chronic hypertension as well,
And
and the electrolyte imbalance, a
and
secondary failure.
and
Um,
associated lesion.
Associated lesion will be cerebral aneurysms in the
Yes.
brain, and yeah.
What should be the management for adult polycystic kidney disease?
Depending upon the presentation, if there is extensive involvement, we'll have to go for nephrectomy and transplant.
Yes. So how would
Um,
you consider transplant before? How would you consider matching before transplant?
we'll have to go for ABO matching and HLA matching.
And what are the types of HLM
The
matching
types
that
of
you
HLA
know of?
matching is basically AA, B, and DR, among which HLA DR is the most important protein. It's a protein located on the outer surface of the WBC, which should be matched against the donor.
Okay, can you please tell me what are the types of rejection, graft rejections that you know of?
So basically, there's a hyperacute, acute, and chronic rejection. So hyperacute is basically when the clamps are released within the minutes following a transplant, the graft failure occurs. This is mainly due to already the presence of already formed antibodies against the donor organ. The second one is acute. It can also be accelerated, which occurs within weeks. Acute rejection basically occurs within 100 days of the transplant.
First 100 days, yes.
And first 100 days following the transplant. This is mainly due to cellular and antibody-mediated injury. And the last is chronic rejection, which can happen over months to years, actually typically over months. This occurs mainly due to graft failure, secondary to atrophy,
Okay.
atherosclerosis.
Can you please tell me what is the difference between polycystic kidney disease and adult polycystic kidney disease? Polycystic kidney disease in children and polycystic kidney disease in adult.
Ma'am, the presentation will be different. The patient will complain of generalized, back pain, lower abdominal pain, and there will be an irregular mass which will be palpable per abdomen. He can present with more paraneoplastic supporting symptoms such as hypertension.
Yes.
The features suggestive of uremia. There could be infection. It's more more prone chance for renal failure secondary to acute, kidney infection as such.
All right. Can you please tell me which malignancy is most commonly occurring with immunosuppressive patients?
In immunosuppression, there can be more possibility for, infection. Squamous cell carcinoma arising on the skin, cervix, and lymphoma and Kaposi sarcoma. There's also
Yeah. Yeah.
propensity for formation of viral carcinogenesis secondary to infections from HBV and CMV infections.
Can you name few common sites for squamous cell carcinoma?
Of the skin, there can be from the
Yes.
cervix,
Yes.
but it's mainly immunosuppressive.
Lymphoma as well.
Lymphoma? I didn't get that question. Hello?
Yes. Okay. Can you tell me? Can you please tell me what is the significance of having increased level of FGF23? Which kind of gene is that?
I'm not sure. I'll come back to that question.
Okay.
Next question.
All right. Why in this patient there was particular raised levels of parathyroid hormones and decreased levels of vitamin D? 125 hydroxy.
It could be secondary to the renal failure, ma'am, or when body trying to maintain the calcium homeostasis.
Okay.
I'm not sure about that.
All right. If a patient has had nephrectomy and then a patient had developed, just suppose because of immunosuppression has developed malignancy and now you are treating the complication, what would you do?
Complication of
Patient, you have transplanted, you have done the nephrectomy and then you have done the transplantation and then patient is developed complications. What would you do?
ma'am, we can try immunosuppressive therapy
Well, you
to
remove
prevent.
the graft.
Oh, you're talking about, okay, sorry. I thought you meant the transplant graft rejection. Sorry. Yeah, you can remove
Yeah.
it.
Okay. Is it always necessary that the patient has to undergo nephrectomy?
In case of infections, is related to the graft.
Yes. Not with the graft, but for this condition.
For this condition, depending on the renal functions and the vitality of the organ, I guess we have to judge on what stage of renal failure the patient is. Some people survive with this disease, but still towards the end, there is renal failure pertaining to this disease, and we might have to consider transplant.
What I meant to ask you if there were any other options available. Okay. One last question. Yes. What might be the complications of the pathology in the longer run if you don't treat?
Secondary to this, the main complication arising is renal failure.
Yes. And
These resulting in renal failure. There can be sepsis and pertinent electrolyte abnormality secondary to that.
no, the one which I was interested in, like chronic pain, okay, hypertension, aneurysm, brain. maybe better.
Presentation. Sorry.
Okay, complications I asked. And then mitral valve prolapse.
Okay, associated.
Yeah,
Yes, ma'am.
associated. Yeah, these were like I said, if
And
pathology is not treated, so that's
liver cyst
okay.
and
Good,
pancreatic cyst, multiple associated presentations. Yes.
good. Now they're telling you differences. Very good. Okay. Yes. Anyone else want to give feedback to Dr. Feedback? Yes, please. Yes, please. Anyone wanted to say anything? It was good, doctor. You could a lot. Thank you. Recording and here started your timer and here is your question. A lot to read. Have you find enough time to read?
Yes.
Should we begin?
Yes.
Yes. If you have read and understood, kindly tell me or discuss the pathogenesis of this condition in the patient. What is your provisional diagnosis? Yes.
A patient presented with severe hemorrhage and transfusion blood. There is maybe post-transfusion blood reaction and massive blood transfusion.
And so what's pathogenesis? What's actually happening? Is there any things that you have noticed which can help you in the diagnosis?
Hypothermia.
Okay.
And massive blood.
Yes.
Yeah.
And the patient was known case of hepatitis C. So
yes, bleeding DISP.
Okay. All right. Can you please tell me what's happening? Is there anything in particular happening? Disseminated intravascular DIC?
Yes, DIC.
Yes. Can you define DIC?
It's about consumption of coagulopathy.
Yes.
Caused by adhesion of coagulation and fibrinolysis, characterized by formation of microemboli in multiple organs and
Yes.
consuming of coagulation factor, secondary hemorrhage.
Okay. Can you please tell me what is the function of platelets?
Platelets play a major role in blood hemostasis, and formation of plaque, and activation of coagulation cascade.
Since the patient is hepatitis C, do you think it will affect patient's platelet formation or function of platelet?
Yes, in the patient with hepatic liver disease, affection of coagulation factor, mainly factor 7, 9, 10, and 2.
Okay.
Vitamin
Can you tell me
factor.
from where platelets are formed?
Formed from fragmentation of megakaryocyte.
Yes, from bone marrow. Okay. Did you tell me all the functions of the platelets?
Platelet, as I said, play a role in first step of hemostasis, formation platelet plaque.
Yes.
And activation of coagulation factor, secreted of serotonin and vasoconstriction.
So can you please tell me what activates intrinsic and extrinsic pathways?
Intrinsic pathway is activation mediated by tissue injury.
Yes.
And firstly, start with activation of 12 and
Factor 12, yes.
and procalcrin.
Yes.
And extrinsic pathway activation by secreted of thromboplastin from the tissue.
Which test can be used to confirm intrinsic pathway
Intrinsic
function?
EBTT,
Yes.
yes.
Yes, good. Can you tell me what you understand by the term hypersensitivity reaction?
Hypersensitivity reaction is a normal body response for harmful agent or stimulating agent.
Okay, host immune system response. Okay, can you tell me how many types there are of hypersensitivity reaction?
The 5 types.
Yes, please.
First one, hypersensitivity is mediated by degranulation of mast cell and immunoglobulin A. And
Yes,
this example for this atopic asthma.
yes.
Second one,
Anaphylaxis, asthma, yes. And second,
yes,
quickly, can
second
you?
one is mediated by globulin G and antibody reaction. This is, for example, is AB incompatibility, hemolysis. Third one, antibody antigen complex reaction, and also mediated by immunoglobulin G. And for example, for this systemic lupus erythematosus. Fourth one is delayed hypersensitivity reaction.
Okay,
And this is example for this is the contact dermatitis and take 2 days to 3 days.
yes.
Last one is autoimmune antibody against the tissue antigen like myasthenia gravis.
Or Graves' disease. Okay,
Yeah.
can you please tell me what is the lifespan of RBC, red blood cells?
120 days.
Yes. What is the group cross matching process? How is it done?
Yeah, group matching is a laboratory test to identify serum antibody against donor surface antigen.
Okay, since the patient has hepatitis C and patient has fractures as well, which you'll be fixing, uh, can can you think that it will involve bone healing as well? What are the stages of bone healing?
Yeah, bone healing is stage 1 is hematoma and inflammation.
Yes.
Stage and this take for days to week. Stage 2 is fibrocartilaginous or soft cartilage. Is take from 2 to 3 weeks. And this stage characterized by angiogenesis, fibroblast recruitment, osteoclast, and osteoblast. And stage 4 is hard callus
Remodeling. Yes.
remodeling. It does take 2 to 3 months. And last stage is remodeling. This,
Okay. Can you
yeah.
please tell me if you'll immobilize the bone for a longer period, how would it affect the
Yeah, this is lead to decrease of bone mass index and matrix, and
bone density? And yes.
yeah, and matrix, and is a risk factor for osteoporosis.
Okay. Can you define osteoporosis, please?
Osteoporosis is a quantitative bone mineral bone defect caused by decreased bone density or bone mass.
All right. Can you define virtue stride? What factors can affect virtue stride?
Focus side, this is hypercoagulability state,
Yes.
stasis, and endothelial injury.
All right. Okay. If patient has infection after you have tried to fix the patient, what kind of organism will be seen?
Most commonly staphylococcus.
Or is yes. Okay. Can you please tell me in this condition when patient has fracture, if you take the calcium levels, how would be the level in the blood?
Is normal.
Yes. Very good. Uh, if you have inserted the if you have fixed the fracture with an implant and it becomes infected, what should you do?
Remove implant.
Okay, so what is the first test to do? How would you confirm that this is infected?
Swab culture and sensitivity.
Very good. And then how would you manage that?
It's a drain of the pus, debridement.
Yes.
And remove the implant if
Very
the
good.
fracture is able.
Yes. All right. Good. Excellent.
Thank you.
Today it was good. Anyone want to give feedback?
It was good, ma'am. We covered all the points. It was really good.
Yeah.
I think one thing you forgot to mention: cross match, group and save and cross match. Basically, group and save is when over here when they check the blood to know the blood group and the RH status of the patient.
Yes.
To check for any atypical blood cells as well. And following which we actually ask for cross match. If you want blood to be sent by the blood bank, you have to ask for cross match. So you have to ask, say, group and save and cross match. So cross when the blood actually issues the blood. So yeah,
Good. Yes.
smart.
Good. Yes. Started the timer, and here is your question.
56.
Right. If you have read and understood, can you tell me what is your provisional diagnosis for this patient?
Patient may have a benign lesion or a malignant lesion. For benign lesion, he may be suffering from acanthosis, actinic keratosis or seborrheic keratosis, and additionally for the typical polypapule, it may be a basal cell carcinoma.
If you can, in particular, consider this in the
Yes.
stem. So
Yes,
what would be the
basal cell carcinoma?
yes? So if you can please look at this lesion here in front of you and describe it. It has been little bit maximized, but still.
There is a polypapule over the skin.
Yes.
With no central ulceration, but there is peripheral telangiectasias.
Yes.
And there is
What
no
does
surrounding
yes?
erythema already.
What does the surrounding skin being red means to you? What does it signify?
These are due to dilation of subepidermal blood vessels, and it is maybe due to some inflammatory element also.
Can you please tell me the steps of metastasis for carcinoma, skin carcinoma?
For carcinoma, first of all, the carcinoma invades into the adjacent normal host tissue and penetrates the small lumen and blood vessels.
Yes.
Then it goes into the blood vessels and into the circulation. Afterwards, the cells that can survive in the circulation, they are arrested in the capillaries of distant organs, and after this, followed by their migration from vessels into the tissues and growth there. So in this
All
way, they are
right, good. So just suppose you have taken the biopsy from this lesion. What would you find on the report? What would the report say or state?
The report would say about the histopathology report would say about the origin of the lesion, its margins, its
Yes.
depth of margins, and its mitotic rate, and there are a degree of differentiation of the lesion.
Can you please tell me the natural history of basal cell carcinoma? How does it take place?
Basal cell carcinoma arises from the basal layer of epidermis just near to the basement membrane,
Okay.
and it is an indolent cancer which
Yes.
grows and moves up and may bleed and go into remission, but it is very less likely to metastasize.
How would you decide how much margin is involved and how deep would you excise the lesion?
For basal cell carcinoma,
Yes,
a 4
please.
millimeter margin
Yes.
I'll take for the
Excision.
excision.
Okay. What other options other than surgical? What other management options can you offer to the
If
patient?
the patient is fit for surgery, I will go with excision. If he is not fit or he is frail and older or he is not ready for surgery or he does not give consent, then there are other options like topical fluorouracil or imiquimod ointments, and there may be electro desiccation, and patient we may go with the photodynamic therapy and cryotherapy.
Yes, even
But these,
radiotherapy.
yes, and even radio, but these cannot provide tissue for diagnosis.
Okay, how would you do or what would you suggest to prevent recurrence of deep margin involvement in reoperation, or how would you confirm that there is no recurrence
To
occurs?
prevent the recurrence of a deep margin, I would ask for operative frozen section of the deep margin to
Very
know
good.
if there is any tumor, or otherwise I can go with the most micrographic surgery.
Just suppose this patient had a lesion excision and has undergone graft placement, which has been rejected. So, what might be the cause?
It graft may be rejected due to infections,
Yes, because
and
of what organism?
most likely it's due to Staph aureus.
Okay. How would you know if the patient has been involved with the, or what are the clinical symptoms if it's growing methicillin resistant staphylococcus aureus?
So in such case, patient will develop redness, erythema, edema over the graft, and there will be purulent material over the graft because of the presence of
Okay.
bacteria.
How would you manage that in
If
that
there is
condition? Yes.
okay, if there is an underlying abscess, and then I will go with the incision and drainage. Otherwise, the patient can be managed with the dressings and giving oral antibiotics.
Good.
In oral antibiotics, I'll give him linezolid, trimethoprim sulfamethoxazole, or give him with clindamycin.
Okay. Can you please tell me the differences between basal cell carcinoma and squamous cell carcinoma?
Basal cell carcinoma arises from the basal layer of just near the basement membrane, while squamous cell carcinoma arises from the superficial layers of epidermis. Basal cell carcinoma arises only on the regions which are sun exposed, while squamous cell carcinoma can also arise on regions which are sun exposed. And also that basal cell carcinoma has a dry appearance. It may ooze or crust very rarely, while squamous cell carcinoma is an open, is just like a wound which bleeds and is itchy.
Can you please tell me about the mode of spread of carcinoma in both conditions and their survival rate?
Basal cell carcinoma rarely spreads into the blood or lymph nodes, and however,
Distant.
it is locally aggressive.
Yes.
while squamous cell carcinoma spreads primarily via lymph nodes.
Yes.
However, it can also rarely spread via blood vessels.
Yes. And what about
And
the rate of survival?
the rate of survival is, sorry, my pass.
Okay.
They have full prognosis.
Yes. No, not full. 96% of victims survive 40 years or over for basal cell carcinoma, whereas for squamous cell carcinoma, all victims survive. So survival is good for squamous cell carcinoma compared to basal. All right. One last question I had to ask you. If you have excised the lesion and the patient develops regional lymph node lymphadenopathy, then you do FNAC, and that reveals, in FNAC, it reveals that there are lymphocytes and there are histocytes and there are cells with bi-looped nuclei. So how would you interpret that report?
In the presence of bilobe nuclei, I would go with the diagnosis of red Sternberg cells, which
Very
are
good.
present in lymphoma.
Lymphoma, very good. Excellent. Good.
Okay, thank you.
Thank you. Yes. Timer, and here is your timer, and here is your question, please. Right. If you have read and understood, kindly tell me how would you manage the patient? What would your reply be?
Ma'am, in this gentleman's case, in the view of persistent dysuria, also a report suggesting an elevated PSA,
Yes.
I would say to the patient that there is a possibility that this could be something sinister,
Yes.
could be representing a malignancy of the prostate, but also in the other chances that there is, because it's only a moderate elevation of the prostate, and also is only one of the symptoms, could be something benign as well. So for that, we need to confirm first with the help of a biopsy.
So how would you take a proper prostatic biopsy? The
Ma'am,
procedure, please.
Transrectal ultrasound followed by a biopsy. For this
Very
position,
good.
for this, the patient should consent it first and then should be in extended lithotomy position.
Very good.
Following that, we first engrave the patient. Following that, we put a transrectal ultrasound probe and visualize the prostate from within the rectum, which will be in a pear-shaped manner. Then we
Very
divide the
good.
prostate into two sides, and then on either side, it will be an anterior, middle, and posterior section. And through under the ultrasound guidance, first we infiltrate the local and numb the area. Following that, we, with the help of a 14-gauge needle, we put in the biopsy gun, and we take biopsies from each side, that is on the parasagittal plane on either sides, and then on the lateral lobes on either side. So six specimens on each side makes 12 biopsies.
All right, good. Can you
Then
please
we
tell
can,
me why it's a must to take multiple biopsies?
ma'am, to get an overall geographic picture, to get biopsies from all the quadrants and all the lobes, there's also a scarcity for the amount of tissue available for histological examination. So we need more sample size.
What do you
also,
understand by the term benign mimickers of cancer?
ma'am,
Okay.
pass. I'll come back to this question.
How would you differentiate between the rectum or the prostate cells in a needle? Is there
We can
any
do
needle biopsy?
immunohistochemistry, IHC markers, and we
Yes.
can, if it's a rectal cells, it'll show positivity for CEA tumor marker.
Can you name few genes, genes mutations which are involved in the pathogenesis of prostatic cancer?
Yes, ma'am. It is TPR SS2 ETS gene fusion gene mutation and deletion of the P13K and AKT pathway.
Okay, can you please tell me when would you indicate or when would you suggest radical prostatectomy to the patient?
Once the biopsy is confirmed of malignancy, based on
Yes.
this, I'll have to discuss the patient's case in an MDT meeting
Yes.
and come up with the outcome and then decide based on the outcome from the MDT whether to what type of management is required for the patient.
Do you think PSA is a reliable test?
No, ma'am. It's organ specific, but not disease specific. So it can be elevated in benign conditions and post ejaculation, post heavy excessive
Yes.
exercise, in prostatitis and infections. So it's not a specific. It's organ specific, but it's not specific for malignancy.
Okay, can you please name few blood tests which can also be used as a key in the investigation for prostatic cancer patient other than PSA?
PSA.
Since it's cancer, so it's ALP and calcium. Okay.
Oh, yeah,
yes. So
ALP,
think
ALP.
what's the main component of white blood cell count, which will increase post-operatively in the patient?
Neutrophils, ma'am. The
Yes,
main component.
neutrophils. Yes.
Yeah.
Okay. Can you please tell me how the grading system is formed for prostatic cancer?
So for prostatic cancer, we do Gleason scoring.
Yes.
So the pathologist basically examines two specimens under the microscope and basically gives a score according to the most prominent cell type which is present. They categorize it into 5. One will be small uniform glands. 2 will be it's increased stroma in between glands. 3 would be distinct infiltrative margins. 4 would be irregular masses of neoplastic glands. And 5 would be occasional gland formation and more. So basically, first stage 1 is well differentiated. The second and third would be moderately differentiated, and the fourth and fifth is poorly differentiated. So we categorize, they score it from 1 to 5 on each slides, and depending upon that, a score of 2 to 10 is obtained. If the score is less than 6, it represents near normal tissue. If it is 7, it's more or less equivocal. It can be sometimes healthy or moderately differentiated tissue. Scores of 8, 9, and 10 suggestive of undifferentiated or poorly differentiated malignancy.
Okay, this patient, you have done radical prostatectomy, and patient comes back after 6 months, just say, and you do the PSA, and you come to find that it's 3. PSA is 3 now. So what would you think? What has happened?
PSA could be a recurrence, but it's not that elevated. I would keep it under surveillance.
Recurrence. How would you confirm your suspicion?
We'll have to follow up the PSA values afterwards, and you can do an ultrasound to check if there is any recurrence.
Okay, maybe CT scan or the bone scan. Okay. Any blood test that you'll add?
We check for bony metastasis.
Calcium and ALP. Okay, what type of mets prostatic cancer has?
It causes sclerotic metastasis.
Yes, why?
Because it causes increased deposition of osteoblastic activity in the spine. So it causes more of dense sclerosis, increased bone formation. Okay,
the same patient that you operated and had PSA 3 comes back after another 3 months, so after 9 months, and now complains of back pain. So how would you manage the back pain after you have found out that there are mets in the backbone?
I would have to think about spinal metastasis in this patient, which I'll have to confirm first with X-ray or maybe a bone scan. Once confirmed, I'll have to manage him with conservative, analgesics and maybe bisphosphonates, and I can consider androgen deprivation therapy in this case.
Yes. Anything else you would add? If you can tell me in the whole from most mild to moderate and severe, how would you manage? How would you go?
I'm not sure about that.
All right, then can you please tell me what's the rationale in treating prostatic cancer with the bilateral orchiectomy?
Basically, prostatic malignancy cells require androgens to develop and proliferate. So androgen deprivation is basically to prevent growth or expression or growth of these.
Yes, and yes, pro-survival genes. Okay. If the patient who has been operated presents with fever and dusky red urine, so what would you suspect?
Would have to first suggest think about infection, post-operative and food infection.
Yes, or UTI. So,
Urinary
what
tract
is the
infection.
most common organism seen in that condition?
In urinary tract infection will be E. coli, ma'am.
Yes, very good. Dalgon. Cement. Okay. Yes. That you can read from you'll add nice, and then you'll add androgens, what you said, and then biphosphonates as well, and then if it doesn't relieve, then you can offer radiotherapy as well.
Okay. First we start off with phosphonate, and then can you say that again? I'm sorry.
Yes, all that you were telling me by Dr. Abhishek has said. Let's hear from him.
Okay.
Yes, please.
Okay, ma'am. It was really great, Dr. Sridhar.
Yes.
The difference between the prosthetic cell and the colonic cell, and it was something like CA tumor marker. So we have solved marker specific towards the rectal cell that is called CD7, CD20. You can just note it. And about the prosthetic tissue, it is, you can say that it's alpha-methyl coenzyme resonance. And about the you have to about to ETS. It's about the acquired genetic condition for, and there's for the congenital one that is in the scene, or that is HOXB13, BRCA1 and 2, MLH1, MSH2. Okay, you can just check that there. And the other options like whenever there is pain, you just go to the WHO pain ladder. Okay.
In particular, this one, Dr. Abhishek,
yes,
not
in
WHO.
One, ma'am, radiotherapy. Yeah.
Yes.
The radiotherapy would be the first choice, ma'am, because
No,
it's bone pain.
not yes. No, it's not the first choice. You'll give the nice medication, what's NSAID, and then biphosphonates,
Also,
and then also you'll add.
Yeah, ma'am, that's all pain ladder. You have to get
Okay.
with the paracetamol, then weak opioids, then strong opioid. In case of malignant specific, that would be radiotherapy also.
Yes.
That's
yes,
it, ma'am.
Yes.
I agree with you. Yeah.
Yeah. All right. Good.
So,
yes.
right about the Gleason's scoring you just described, that's definitely good. I just only followed the notes. Yeah.
Good.
And often, right, Dr. Sridhar?
Treatment of
like cancer when it is metastatic or non-metastatic, something like that.
Yeah, depending upon the MDT outcome, you have to go for either radical or surgical options. That's the only treatment. Otherwise, if it's too overtly metastasized already, then we have to consider conservative management of palliative approaches.
Conservative palliative, yeah, that includes the castration, surgical one or medical one, or hormonal therapy or radio, something like that. Yeah. That's it. And about if it is not metastatic, then the treatment protocol is totally changed to go for the radical prostatectomy or radical cystectomy. Yeah, that's it. Good. Dr. Sridhar, it's a nice one. That's all from me.
Good.
Yeah.
Anyone else want to add anything? You can move on otherwise. Good. Started the timer, and here is your question. Right. If you have read and understood, kindly tell me what's the significance of seeing a hyper enhancing pancreatic lesion on CT scan?
So as the patient has a history of hyperparathyroidism for which he
Yes.
was treated, and now he has a complaint of this pancreatic lesion. So he may be a patient with MEN1 syndrome, and it
Yes.
may be a pancreatic neuroendocrine tumor.
Very good. Can you define hyperplasia?
Hyperplasia is the increase in number of cells as a result of physical or chemical stimuli or any other stimuli.
Good. If a patient has hyperparathyroidism, so how many glands are affected?
In cases of sporadic there are single gland hyperplasia or adenoma, while in
Yes.
cases which are familial in MEN syndrome, there is four gland hyperplasia.
Very good. Can you tell me what should be the microscopic picture of hyperplasia?
There is chief cell hyperplasia and
Yes.
clear cell hyperplasia,
Yes.
and in some cases there will be islands of oxyphil and fibrous strands which form the nodules.
Okay.
Most common is the chief cell hyperplasia.
Yes, good.
Yes.
If the patient develops stupor, confusion, and hypoglycemia, what might be the cause for these
So the
symptoms?
patient may be suffering from insulinoma,
Yes.
and as these are the symptoms for hypoglycemia, and his yes.
What might be the reason for insulinoma?
Because patient has got pancreatic neuroendocrine tumor, and the most common neuroendocrine tumor is then insulinoma, which arises from the beta cells of pancreas.
Okay. Can you define the term Whipple stride? What does it include?
Whipple's triad includes the patient initially the symptoms of hypoglycemia like confusion, stupor, or loss of consciousness,
Yes.
and these symptoms are precipitated by fasting or exercise, and these symptoms are later relieved by feeding or parenteral administration of
Very
glucose.
good.
This is the whole of the Whipple's triad.
Can you please tell me or name few other conditions which can also present with hypoglycemia?
It can be an acidoplastosis.
Yes.
Diffuse liver disease can present with this
Yes.
hypoglycemia and increased insulin sensitivity. And in some patients with the retroperitoneal fibrosarcomas, they also present with hypoglycemia.
Very good. How the biochemical diagnosis is made?
For biochemical diagnosis, we check his blood sugar levels. They should be below 2.5 millimole per liter, and additionally, we check the insulin levels, proinsulin levels, and the C-peptide levels. And for localized, and for additionally, we check for insulin to glucose ratio, which is high in such patients.
Very good. In a patient with insulinoma, what other pathology would you suspect?
Uh, Other additionally, he may also be suffering from a pituitary adenoma.
Okay. So if you can please tell me in this insulinoma, it is derived from which genes? From which gene
Men,
mutations? Yes, please.
MEN1 syndrome is associated with the mutation in the menin gene, which is located on the chromosome 5, and it causes this syndrome. And additionally, there are some mutations of the loss of function mutation of tumor suppressor genes, which are the P10 and P10 genes, which cause activation of the mTOR pathway. And there are also inactivating mutations in other genes which are involved in maintaining telomeres.
Can you please tell me what is the normal insulin level?
Normal insulin level is, I think, less than 10.
Yes, or more than 10 micromole per milliliter. Okay, what blood test you can do to diagnose or confirm your diagnosis of insulinoma other than glucose or insulin?
We check for the C-peptide levels,
Yes.
insulin levels, and there is a high insulin to glucose ratio in patients with insulinoma.
Yes. Right. Okay. Right. If you can please tell me what is how is apoptosis considered to be a physiological process in the body, or what is apoptosis?
Okay, apoptosis is a programmed cell death which occurs in multicellular organisms, and it is due to it starts from the nucleus, and there is alteration of and it is started in response to cell damage caused by radiation or with an abnormal DNA in the cells. It is a physiological process and it does not lead to inflammatory response. And the process of apoptosis starts in the nucleus, while in case of necrosis, it starts at the periphery from the cell wall.
Okay, can you please tell me what is telomere?
Telomere is telomere is a region of the repetitive nucleotides which are present at the periphery of each genes, and they protect each genes from fusion with the neighboring chromosomes, and also they protect the end of chromosomes from deterioration.
How would you
And
differentiate men 1 from men 2?
in
What
men
will
one
be, yes,
syndrome, in men 1 syndrome, there is pituitary adenoma, hyperparathyroidism, and pancreatic neuroendocrine tumors, while men 2 has further subdivided into two. Men 2A has pheochromocytoma, medullary carcinoma of thyroid, and hyperparathyroidism, while men 2B has medullary carcinoma of thyroid, hyperparathyroidism, and Marfanoid syndrome, Marfanoid habitus, or mucosal neuromas.
what is the oncogene mutation for men 2?
Men 2 is due to mutation in the retinoblastoma gene.
Yes. So what is the mode of inheritance of men 2 syndrome?
Men 2 is due to autosomal dominant
Dominant.
inheritance
Yes.
of retinoblastoma gene,
What
RET gene.
test would you do to confirm your diagnosis for men 2?
To confirm the diagnosis, I will go with the urinary metanephrine levels, and
And
further I can go with the blood levels of epinephrine and norepinephrine.
good.
Okay,
Yes, thank you. Just looking
thank
if
you.
I've missed any question. Good. Okay, for men 2, one last question, very important, please. For men 2, what would you like to exclude before offering a surgical option to the patient?
Okay, as the patients with men 2 are likely to have pheochromocytoma,
Very good.
which may lead to exacerbation during anesthesia, so I'll rule out pheochromocytoma first.
Very good. Good, good, good.
Okay, thank you.
Thank you. All right. Anyone want to say anything?